Now we have with us Dr. Vinay Garodia, who is a excellent retina person and a retina specialist in Delhi. And basically I'm Sonian, and he'll be talking us about the laptop lagaya, please. And he'll be talking us about the wide field imaging system.
Hi, thank you, sir. And one thing more I would just like to add after that excellent presentation on ultrasound, that one other thing that I used to learn with was that in a clear medium also, if you see a detachment, do an ultrasound. Because there you know the diagnosis, you do the ultrasound, so you learn from how it looks like. Also, if you're operating on a patient with an opaque medium next day, do an ultrasound before, on the OT table, see what you find. So that's where your reinforcement of your learning will happen. So, we don't only do ultrasound in the opaque media, do it in the clear media also and learn from that. So that's one thing that practically actually helped me quite a lot during my training.
And I think we can have questions just at the end of the session. You all just note down questions, and we'll do it at the end of this, all these sessions.
So now coming to the next talk, that from speaking from when we could not see anything to when we want to see lot more. So we'll be talking about ultra-wide imaging systems. So, and a very interesting thing, I have one of the slides here which is comparing the various UWF systems that we have. And while I was going through the stalls yesterday, you were seeing that every company is coming out with it. I saw Appa Swami has also come out with a new model that they're working with. Remedio people are also coming with it. So there is a huge amount of interest in ultra-wide imaging system. So therefore, we are going to be talking about what is it and why are we interested in it. So first of all, let us know what it is, right? So there's a definition because, everyone will start to claim that we have an ultra-wide system. So what exactly is ultra-wide field system, right? So first of all, wide field is something which is beyond the posterior pole, right? But it is posterior to the vortex vein. Right? But if you're talking about ultra-wide field, then in all the four quadrants, it should be beyond vortex vein. So that's when you're really talking about ultra-wide field. And a pan-retinal will be something where you can see from aura to aura. We still don't have a very good system for that yet, but ultra-wide fields are now available. So wide field is different from ultra-wide field. And again, we always had a montage system with the regular fundus cameras also, but the disadvantage is, one, it requires pupillary dilatation, and it requires you to take multiple photos. Then earlier we used to do a manual montage creation. Now, of course, most of the machines have an automatic one, but still it is much more cumbersome for the patient and for the clinic also to do all that activity. So basically, if you can see in the pictorial thing, the same thing, this is the posterior pole that you see. And this is the mid periphery, which is basically covered by the wide field. And when we talk about the far periphery, it is covered by the ultra-wide field. So beyond the equator, if you are seeing in a single go, that's ultra-wide field imaging system. Just to compare the field of views that you have, so first of all, the smallest you have is by a slit lamp biomicroscopy. This is how much you see. Then this is you see by the direct ophthalmoscopy this much, indirect ophthalmoscopy this much. This is the regular fundus camera, about 40-45 degree of view that you would have. This is the wide field that you can see, and this complete picture is what you can see at about 200 degree of retina is with the ultra-wide field system. So this is just a comparison of how much you can see. And again, comparing with the ETDRS 7 reference points. So if you can see in a single ultra-wide photo, you can capture all the area that is of interest as far as the diabetic retinopathy is concerned. So rather than taking multiple photos and trying to stitch it together, this is much more convenient thing to work with. So just to compare the various machines available, of course, we need to add many more columns to this as the time goes by. But basically, we have Optos is what we have. We'll be talking about the Optos machine, but it comes with a Daytona in California. Daytona is the one which has got a basic fundus photo and a FAF, autofluorescence. California has an added fluorescent angiography also attached to it, but that becomes prohibitively expensive, and now we do less and less angiographies nowadays, so therefore we haven't taken that. So I don't have an experience with that. Then the other option is Carl Zeiss, Claris, Heidelberg, Spectralis, and Nidec Mirante. ION is not really a wide field, it's a small angle thing. So if you see, the maximum angle of coverage is in Optos. In a single shot, you can get about 200 degree, whereas the others are covering about 100 odd degrees. It covers about 82% of retina in one go compared to about 40-50% that the other machines will be covering. And it can work with as little as 2 millimeter pupil size. And that is the most interesting part, because that makes it much more convenient to use for the patient and for the center both. And the resolution is, of course, not as great as that of Claris, But as a screening tool, it works pretty well. So as I'll be talking about, see, the basic purpose is one, screening so that you don't miss out any diagnosis, and other is to actually make out the pinpoint diagnosis and to document it. For that, it is not a very, very good tool because the colors are not the true colors, the resolution is not that great, but nothing can beat a good direct or indirect ophthalmoscopy. So once you find that there is something, then you have to, of course, supplement it with a good indirect ophthalmoscopy. It's not a standalone thing for everything, but it does work as a very, very good screening tool, and you can pick up lots of things as I'll be showing you. So this is the machine, and this is how it covers about 200 degrees. So it almost the whole of retina gets covered except for some periphery, which you can again take images with the various directions, and you can stitch it together. That's how you get almost 90% plus of the retina with this, in contrast to about 45% coverage with the regular fundus camera. So it gives you 200-degree field, non-mydriatic 2mm pupil, fast acquisition. So the acquisition time is what really excited me for this. So I bought this machine just based on, it takes a few seconds to acquire an image. So it's very, very convenient to work with. And other very interesting feature that I find is the patient, I send them for an optos, they get the optos done. By the time they come back to my OPD, I already have those images open on my computer system. I'm already evaluating that. When they come in, I tell them, okay, this is what you have. And by the time I'm done with the patient, they go out. By that time, they get the printout. So the overall flow becomes very, very smooth. And you can play with the image on your own system. You don't have to work on a printed image or something. You can increase, magnify, move around. You can change the color pattern and all those things, and you can show it to the patient. So it's a wonderful tool. And the networking system is one of the best that I've seen. And it, of course, has multiple imaging modalities. Just to briefly tell you how this thing works. So basically, there are two ways that you can capture the images. The patient has to tilt the head a bit to the side, and then there is a green. When the green comes, that means it's the ideal position of the patient. It can either auto capture, that means whenever the green comes, the machine is going to capture, or you can have a manual capture where the operator can touch the screen and it can capture the thing. So it depends upon your patient. And this is one thing with which you can take a selfie of your own. So, I mean, that's an easy thing to do. So you can take a selfie of your retina. So here it's a manual capture that is being done. And the basic principle of the machine is that it basically sends two lasers, the red and green lasers, and they are scanning. This is basically a SLO-based system. And they scan the whole of the retina, and then they restitch the image using the processors, and they combine the two lasers to create a pseudo color. And because they are scanning all over the place, therefore they can work through a very small pupil. So because of SLO-based system, it is a non-mydriatic and it can cover a huge area. So that's the basic principle. And the options that we have is, of course, as I said, there are red and green outputs that you have. So it combines that to give a pseudo color image. And you can also see them as a separate channel. So you can get a red-free image that is very good for looking at the surfaces and looking for any blood or any blood vessels. That comes out very nicely. And the green-free or the red channel shows you the deeper level of choroidal area. And you can also do a fundus autofluorescence with that using a 532 nanometer laser. Autofluorescence, as we all know, it's a non-invasive way of looking at fluorescent properties of the lipofuscin of the RPE layer. And it shows about the metabolic status of the RPE. So that helps in a few cases. Hydroxychloroquine toxicity can be one place where it can be of much of use. And also in cases of drusen, it can pick up very well. You can pick up a lot of CSR cases where you can do an FAF, you can find the older lesions, you can see the RP atrophies there. So some of those places you can just get away with the angiography. So this works as an additional tool. It comes without any additional price, so we can use that. Now, this is a particular patient I wanted to talk about. There's a around 30-odd-year-old lady who came to me towards the evening. And she had been to 2 or 3 doctors with some vague complaints, 6/9 vision. And she said, okay, I'm having some problem. I said, I would like to check your retina. And she was refusing to dilate because she said, I already had that checkup 2 or 3 places. I don't want to dilate, just do that. I just kind of convinced her to get an optos done. I said, okay, let's just do it for the sake of it. Because the things were not kind of fitting right. And there we realized there was a macular hole with a detachment and which was yet not involving the macula. And this patient otherwise would have been just seen by me. She refused dilatation. She would have gone back to Australia and then had a detachment and complications there. And because we could show that to her on optos, she cancelled her ticket, got operated the next day, and she did well. So, I mean, this was one patient where I actually recovered all my investment on optos. Not that I charged her 50 lakhs rupees, but if you can save one eye, you feel that yes, you've used that. And after that, there have been so many instances. Like this Thursday, I was not in town, I was outside, and a patient came, again, he refused to dilate, but he had a loss of vision. And Dr. Mashwata got a optos done for him. I detected that he had a detachment. After showing the photos, then he got convinced that yes, he has a problem. And next day morning, he was at my operating table at 9 o'clock. So it can really help those patients who are refusing to dilate. Is it better than indirect ophthalmoscopy? No, it is not. A good, thorough indirect ophthalmoscopy is any day better. But the problem is a good and a thorough indirect ophthalmoscopy with a dilated pupil. Many times the patients don't want to dilate, sometimes you are tired, and to be honest, we are not as perfect when we do indirect. When you're doing an exam case, you're looking at each and every clock hour, but normally on a busy OPD, you tend to see and you tend to miss out things. So now this is a standard RD with an HST in the right eye, and another patient seems to be a mirror image of the same thing in the left eye. So you can just, when you show these images to the patient, it becomes very easy for them to understand what the problem is, and then you can convince them for the treatment very easily. Now this young boy, just before his board exams, came to him with a traumatic, such a large tear, and we could just check that the macula was still on, and because we could show that thing to him, they understood the gravity of the situation. He continued to take the exams, but with restricted activities. We did lasers, we did cryo, and so this is about 1.5 years old photograph, that this one, and the child is still doing well. So we are keeping a close follow-up on him. So this again helps to convince them. Another patient where you can see the right eye has been lasered, lattices and holes. Left eye, some lasers, you can see some fresh retinal tears with some localized detachment. And this patient again underwent a laser treatment and gained good results. And you can see some bit of opacities here. Now this is the bit of shadows from the vitreous hemorrhage that was there. So vitreous hemorrhage on an optos will look like an opacity because it's blocking the rays. So this, you won't see red bleed, but you'll see these as black opacities there. Now this is another patient with lasered retinal holes. This is an operated retinal surgery with you can see the peripheral delimitation, and also you can see the whole of retina, and you can see which all areas you have not covered well. So that way it helps to pinpoint where all are your gap areas that are there, because even when you do indirect, we don't really draw it the way we should and mapping each and every clock hour. So this gives you overall picture, you can plan your treatment better. This is a patient of a PDR where he has a subhyaloid bleed along with, you can see some bit of these vessels which are very easily visible on the FAF images. So you can see those vessels are standing out quite clearly, whereas on the normal, this image, it is not that clearly visible. So sometimes if you work on a FAF or a red-free image, those hemorrhages are much more easily visible. So you can just play with that in front of the patient to show them what it is. This is again a normal laser PRP. This is a resolving CRVO. You can see that the peripheral vessels are all sclerosed here all around, but the hemorrhages are resolving. This is retinitis pigmentosa, the color photo, and along with the FAF, you can see that peripheral all scar tissues that are there, and increased area of RP activities in the central area, which is seen by hyperfluorescence areas on FAF. Now, you could even pick up some ROP patients also. You put on a speculum and go in like a flying baby, take it there, and if you're lucky, you can get some good images also. So here you can see that there's about stage 2, stage 3 ROP changes that we could pick up in zone 2. So sometimes it helps to document your images. This was an interesting, just for the artistic, the albinism photograph looks beautiful. You can just see the whole choroidal vasculature. So this is something which is there, heel multifocal choroiditis. So to conclude, the benefits, what are the benefits? Of course, the patient gets the benefit of early detection and very fast and convenient. So most of the times you just need to take a single photo, a single flash, and everything is done for him. Non-mydriatic, so the patients can go back home immediately, they can drive, and especially if you're working with people who are working professionals, it becomes very easy for them. Many times we ask the attendants, if you are a diabetic, why don't you also get a checkup done? So the apprehension of getting dilated and all is gone, they just get a checkup done, they know whether they are okay or not. And we don't still compromise on the quality of the treatment. Helps them understand the disease better, make the right decisions, better compliance, especially for diabetics and macular degeneration or detachment patients. The benefits to the practice, easy documentation, better patient education, increases the compliance to the treatment, especially for the things like lattices and retinal tears. You show them, they are more likely to get treated. Otherwise, they say, I'm perfectly okay. Saves the waiting time. So if you've got a busy OPD, your overall waiting time comes down to half. So you can utilize your parking spaces better, your waiting spaces better. So overall, the system works much more smoothly out there without compromising on the quality. Smooth workflow, patient experiences goes up. You can, non-dilating pupils like uveitis or in a corneal opacity where you've got a very limited window from which you can see, you can still have a look at the retina. So I often joke now with the wide angle systems coming in, we can do retina surgeries from 3 or 4 millimeter pupil, we can do fundus imaging from this. The only thing that we need to dilate pupil is for the lasers, because that's what we have to dilate and do it. So that has made our life much, much more easier. With the wide angle system, we can operate at a small pupil, so things have really helped there. And screening all the patients who are unwilling to dilate, picking up lesions even after so-called thorough examinations. So often I've picked up 2 or 3 lattices and say, okay, fine, I'm just doing an Optus for the screening thing, and I've picked one more that I had missed out. So it always helps. The limitations are, of course, the high cost of machine, the eyelashes which often come in the upper and lower field, that is there, but often people joke about Optos being bad because of eyelashes, but it is also because it is such a wide field, it's picking, therefore it's picking eyelashes also. So, but upper and lower part, you may miss out things. So ideally, you should do both. If you're suspecting a patient to be having some problem, do an Optos and do an indirect both, because both can miss out some parts. So 90% sensitivity together will be about 96-97%, I suppose. But not viable if your workload is less, because it's an expensive machine. So if you've got a patient load of more than 10-15 or so, and if you feel that there's a shortage of space and your patients are the type who would like the convenience of not getting dilated, it's a good thing for you. The pseudo colors are a concern for some people, but honestly, I don't find much of a difference. This is an RG photograph and this is the RGB photograph. Of course, the colors are closer in RGB to the natural colors. But if I'm thinking of it more as a screening tool, there is not a single patient where I could not make that there is something wrong with the eye. And you can always dilate and see. So there's no point spending more money on an RGB thing. I would rather have something with a bigger field of view and convenience rather than getting a better picture from Mirante or something where the acquisition time is longer, the patient waiting becomes more. So this is much more convenient for me. So if there are any questions.
Any questions you have? So thank you, Dr. Vinay, for a very nice talk.
Sorry? Oh, sorry. I'll give him a card. Okay. Thanks.
क्या चाहिए उसको? अच्छा. मैडम माइक ले लीजिएगा. माइक प्लीज.
Where you have to laser patients.
Of course, see, I mean, if it was really going, then Marsha would not be coming up next after me. but we are doing less and less and much less. So I think the reason I said that this costs about 55 odd lakhs rupees. The one with the FA module costs 1.2 CR or something. So to spend that kind of an extra money for getting an FA of a wide angle field, for an institution, yes, that may be okay. But for individual practitioners like me or with a smaller group like us, it is not really a cost-effective solution. So that's what I said. I'm not saying that it's out, but the peripheral, we used to do FA scopies during our residency time. So if you really want to look at the periphery, you can always do an FA scopy. Or if you're doing an FA, if you can ask the patient to look at various fields of direction, you can pick up most of the wide angle areas there. So for that to spend another 70 lakhs of rupees and you're doing only 2 or 3 angiographies in a month, it's not worthwhile.
And with UVR practice in place where an Octa doesn't replace fluorescein angiography.
Of course not, yeah.
So there, in addition of an FA, this kind of wide field imaging.
So UW works beautifully in UVR cases because of smaller pupil, you are not able to see the periphery so well. So you can do that, you can see the periphery almost pretty well with that. Some cases of pars planatis I picked up in a smaller pupil because it was not visible otherwise. But with this you could find those snow banking there, so there it helps.
Thank you so much.
Thank you.
Thank you, Dr. Vinay.